A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Today our next lecture will be therapeutic use of radiopharmaceuticals. This is the scope that I will cover during this lecture. I'm hoping that at the end of the lecture, you will be able to understand how radiopharmaceuticals are used for therapeutic and also understand the clinical application of the radiopharmaceuticals for treatment of a specific diseases. Yeah. And this would be the outline of my presentation, which cover a bit of introduction. You really need to understand the properties of therapeutic radiopharmaceuticals. Then we're going to move into see the use of the radiopharmaceuticals in the common diseases that we are handling in our nuclear medicine department, which is the hypothyroidism, as well as thyroid cancer, followed by bone pain. Some of the center might use it and start planning of starting to use it. Third, selective internal radiation therapy, that I would say the case is quite numbers in Institute Cancer Negara facilities. Radiosynovectomy, it has been run in Hospital Kuala Lumpur quite years already, and Hospital Pulau Pinang has already started of these services. What is the radiopharmaceutical use for the neuroendocrine tumor, as well as what are there for our radioimmunotherapy. So in this picture, I would say that you are able to differentiate those external beam X-ray therapy compared to our nuclear medicine therapy. So on the left, figure A is the external beam X-ray therapy that uses an external sources of radiation and focuses the beam to a localized region of tumor. So for our cases, for the radiology department, they will have the radioactive sources from the machine that gonna be emits and radiates to the tumor cells inside a patient's body, meaning to say the radiation comes from outside the body and focus into the localized region. Whereas for our nuclear medicine department, for this example, the radioimmunotherapy, which involve the injecting of radioactive labeled antibodies into the bloodstream, then it will be brought into the area of the tumor, accumulates there, and then it will radiate, localize in that area, which will cause the cell destruction to those tumor area in that patient's body. Okay, so I'm hoping that you are already understood the difference between those area by now. So how does actually radiation therapy kill cancer cells? So radiation therapy kill cancer cells by damaging their DNA. It can either damage DNA directly or create a charged particles, the free radicals within the cells that can in turn then damage the DNA lah. So cancer cells whose DNA is damaged beyond repair, they will actually stop dividing or die. So when the damaged cells die, they are broken down and eliminated by the body's natural processes. So for an external beam, it delivers the same absorbed dose per cells, regardless the number of cells. Whereas in the radiopharmaceutical therapy, the absorbed dose is delivered per cells by emission originating from cells is influenced by the range of the emission. So it depends on the radiation energy, the radionuclide, what is the range of emission for that particular radionuclides. And it also depends on the numbers that are clustered together and the number of cells that have been targeted. So a single cell, it's quite difficult to sterilize with the radiopharmaceutical therapy. So if the range of the emitted particle is much longer than the dimension of the cell nucleus, so we can see a smaller fraction of the total emitted energy will be absorbed in the nucleus. So what is the people call it as a systemic radiation therapy or targeted radionuclide therapy. Why is it being claimed so? Yeah, because when we are saying about targeted, it will deliver the radiation to a very specific tissue or area. And obviously, we are using the radionuclide as a radiation to destroy the lesion. And yes, obviously, it's been used as a therapy because it's going to be for the treatment of the benign or malignant lesions. So when we are talking about targeted radionuclide therapy or systemic radiation therapy, we need to say that this therapy is using radiopharmaceuticals, which involve administration of radiopharmaceutical either orally or by injection. Orally is the example of our radioiodine, our iodine 131. It comes in a solution or capsule that patient need to ingest orally, or sometimes it's going to be injected intravenously to the patient. And this therapy also utilize the use of unseen sources of radioactivity that make us different to what a radiology is doing, whereby they have this sealed source inside the machine that gives the radiation to the patient at the local sites which are required. But for us in nuclear medicine, those radiation therapy would involve the injection of the unsealed source. Okay, and then the drugs will work at cellular level where they cause the destruction of the cells within the tissue or organ where they localize. Okay, they will go into the specific target organ. So it is very important to use the radiopharmaceutical that provide a very high degree of localization in the target tissue. So it will give little or no normal tissue background activity, and it won't actually destruct the normal cells around it. Yeah. So when we are saying about therapeutic radiopharmaceutical, we use the radioisotopes which emits a short range particle. It's going to be our alpha or beta, and sometimes people are using the photon emitter. So this radioisotope, they will loses all their energy over a very short distances. So therefore, during their travel, they will cause a lot of damage, meaning the cell destruction will be happening. So this property is used for therapeutic purposes, which in the cancer cells destruction, pain treatment in palliative care for bone cancer or arthritis. So such isotope, they will actually stay longer in the body than the imaging ones. So this is intentional in order to increase the treatment efficiency, but it remains limited to several days. So now we are going to look on the properties of the therapeutic radiopharmaceuticals. For therapeutic purposes, Radiation with high linear energy transfer, the LET, such as alpha and beta particles are preferable. Because this type of particulate radiation, it will allow a very high ionization per length of travel. So during the length of travel, as I've said just now, it will cause the cell destruction. Therefore, they are fully deposited within a small range of tissue, usually in millimeters distance lah. This is also will reduce the need for additional radiological protection because the radiation, it won't penetrate through the patient's body. It will just concentrate on that particular area because their punya travel range is only a few millimeters distance. However, we have to bear in mind because there are some beta emitting radionuclide which also decay with gamma radiation. So those associated with the gamma radiation could be advantageous if the energy and intensity are within the diagnostic range. Why? Because it will enable us to visualize the distribution of radiopharmaceuticals within the patient's body using the gamma scintigraphic method. So this is advantage lah. If the radionuclide, in addition for it to be the pure beta emitter, it also have some beta emitting decay. So we can use it for both purposes, for the diagnostic as well as the therapeutic purpose. Okay. And then depending on the type of tumor, the energy and intensity of the emitted radiation should be chosen so that the energy and intensity of the non-penetrating radiation are high enough compared with the penetrating radiation. It's either the gamma radiation, X-ray or Auger electron, if there's any lah yang present. So radionuclides that emit energetic alpha ataupun beta particle, they are preferred for the treatment of a bulky tumors lah. However, for the treatment of a small cluster of cancer cell or small tumor deposit, radionuclides that emit Auger electron are considered to be more beneficial because of their high level cytotoxicity and also the short range of biological effectiveness. So on top of other properties, obviously it need to be long effective half-life. We want it to be targeted at the specific cells or organ so that it can concentrate on the area and give the cells destruction at those particular and not other normal area. Obviously, it needs to be readily available and relatively inexpensive, and also it gives a minimal radiation exposure to the personnel who involved in the dosing of the patient. So now we can see this is the tracer or radionuclides that are available for the use of therapy in order of maximum range. As I've told you just now, those beta particles or Auger emission, they will travel in such a very short distance, but with a high energy LET, it will give a very high destruction to the cells. Okay, one of the hallmark of radiopharmaceutical that use in therapy is their ability to deliver highly potent form of radiation directly to the tumor cells lah. So three different types of radiation are relevant for us to really understand. Is about the photon, electrons as well as the alpha particles lah. So photon, they comes into two flavors or two ways. It's X-ray as well as gamma rays. So the former, the X-ray, are derived from orbital electron transition and are typically lower in energy than gamma ray. So the radionuclide photon emission, they are useful for imaging the distribution of the radiopharmaceutical that is used for therapy, but they're not for localized delivery of cytotoxic radiation. Okay. So if we can see in those table, so this is been categorized based on the maximum range that they can travel. So you can see the bromine 80M, iodine 125, astatine 211, erbium 169, yeah, copper 67, iodine 131, which are very commonly used in our nuclear medicine department, and you can see that this has both the properties of beta as well as gamma. Same goes to samarium, rhenium 186 and others, yeah. But for the strontium, phosphorus as well as yttrium 90, they are purely beta emitter with a bigger maximum range that they can travel with. All right, so afterwards we can see with this kind of properties what sort of disease that they can use for. So in addition to those mentioned before, there are also other radionuclide that has been explored recently, such as lutetium-177 with the beta therapeutic emission, and then we have this astatine-211, yeah, this alpha emitter that currently exploding the use of it, been researched in the nuclear medicine centers. We've got these lead-212 or bismuth-212, radium-223, actinium-225, as well as thorium-227. Now you can have a look on the publications per year related to the radiopharmaceutical used for the therapy. So the figure shows the introduction and expanded use of new beta particle emitting radionuclides for the therapeutic use. For example, the lutetium-177 was first described for use in 1991. By 2018, the numbers of publications related to the lutetium-177 and radiopharmaceutical use for therapy was about the same as that for the yttrium-90. Okay, so you can see at the early years, in nuclear medicine, there are a lot numbers of publication related to the iodine-131, but then it been explored on the yttrium-90 as well as lutate-177. Okay. So this is the publications per year related to the radiopharmaceutical used for therapy using the alpha particle emitting radionuclides. So I think you have already studied or learned about the alpha particles, which are the helium nuclei. It involves 2 protons and 2 neutrons that are emitted from the nucleus of a radioactive atom. So depending on their emission energy, they can travel between 50 to 100 micrometers in the tissue. So they are positively charged and are orders of magnitude larger than electron. So the amount of the energy deposited per path length travel, their LET, linear energy transfer, is approximately about 400 times greater than of electrons, and this will lead to the substantially more damage along their pathway than that caused by the electron. So, alpha particle, the threat leads to the preponderance of complex and largely irreparable DNA double-strand breaks lah. So, the absorbed dose required to achieve the cytotoxic will relate to the numbers of alpha particles, yeah. That transfers the cell nucleus. With the use of these as a measures, the cytotoxicity may be achieved with a range of 1 to 20 alpha particle traversals of the cell's nucleus lah. So the resulting high potency combining with a short range of alpha particles, which reduces the normal organ toxicity. It won't goes up to the normal area. It has led to a substantial commercial interest in developing these alpha particle emitting radiopharmaceutical that used for the therapy lah. So the alpha particle emitters introduced and used for radiopharmaceutical therapy over the last 40 years include these astatine 211, our bismuth 212, the lead 212, the lead 212, and then bismuth 213, actinium 225, as well as radium 223, and also thorium 227. So this is the publications related to the radiopharmaceutical use for therapy for the each indicated malignancy lah, according to the type of cancer, yeah. So you can see the those area being focused is the obviously hematological malignancy, our thyroid cancer, the neuroendocrine, SSR, prostate cancer, breast, hepatic, as well as a colorectal cancer. So this is the commonly used radiopharmaceuticals for targeted radionuclide therapy. The first one is the common radioiodine, our iodine 131 iodide, with a targeting mechanism of thyroid hormone synthesis. It is indicated for those patients in differentiated thyroid cancer, grave disease, as well as hyperfunctioning nodules. And then we've got this yttrium 90 microsphere with the mechanism of intravascular trapping in patients with liver metastasis as well as hepatocellular carcinoma. This will be covered in next few slides. Yeah. And then we've got the strontium 89 chloride, which is a calcium analog for bone pain palliation. We also have this samarium 153 EDTMP, the chemoadsorption to the bone for the bone pain palliation. And then yttrium 90 octreotide based on the somatostatin receptor binding for the neuroendocrine tumor. And then iodine 131 MIBG actively transported into the neuroendocrine cells and intracellular storage for the neuroblastoma, pheochromocytoma, carcinoid, paraganglioma, as well as medullary thyroid carcinoma. And then this is the other therapeutic application of the nuclear medicine, which is specifically in the oncology. So you can have a read later. And some of it I will introduce more in my lectures, especially those that are commonly used in our facilities. Okay. So, the most important factors to be considered when we are choosing a suitable radionuclide for therapy is the effective half-life, which is the net half-life considering both physical half-life as well as biological half-life within the patient's body or organ. So the determination of the effective half-life is explained in the medical internal radiation dosimetry MERT calculation method. And the physical half-life is readily available from published radionuclide data, but the biological half-life require knowledge of the radio traces special as well as temporal distribution within the body. So these will include how the radio trace have been delivered, how's the uptake of it, metabolism, clearance, as well as excretion within the patient's body. So we're going to move to our first disease, which is the hypothyroidism and thyroid cancer. So it is a clinical state due to the excess thyroid hormone. There are two hormones which are produced by the thyroid gland. One is the T3, our active hormone, and as well as the thyroxine T4. So the excess thyroid hormone, the cause of it include the Graves' disease, toxic multinodular goiter, toxic adenoma, as well as others. So for the management of hyperthyroidism, there are three forms of therapy that is available. If either we use the antithyroid drugs such as cyanamides, or patients will undergo the surgery as well as the use of radioiodine. So the treatment may also be necessary for the complications such as atrial fibrillation, cardiac failure, or ophthalmopathy. So the method used will actually vary according to the cause and severity of the disease, the patient's age, as well as the resources which are available. So in terms of the medical treatment, we have thionamides, our carbimazole or propylthiouracil. It is a commonest form of treatment that can be used for most patients with the hope of achieving the long-term remission lah. So this drug may also be used in preparation for surgery as well as radioiodine therapy, and that is the schedule for the administration for those antithyroid drugs in adults. In terms of the surgery, thyroidectomy may be performed in Graves' disease, toxic multinodular goiter, or toxic adenoma. That is the indication why the surgery is needed, and the pre-operative preparation is actually needed to control the thyrotoxic state with the medical treatment, but we have to ensure that we can avoid the hypothyroidism. So in the last 1 to 2 weeks, the potassium iodide or Lugol's iodine is needed to reduce the vascularity of the thyroid gland. So, radioiodine therapy in the nuclear medicine is safe and they are appropriate in nearly all types of hypothyroidism. However, it should not be used in pregnancy and women who are breastfeeding. And in general, radioiodine therapy is not recommended in children unless that we don't have any other method that can be complied with. The precautions, the patient need to avoid close contact with young children and pregnant women for a duration of at least 10 days after the radioiodine therapy. Women are also not advised to women are advised not to become pregnant at least 4 to 6 months. And severe and complicated hyperthyroidism need to be adequately controlled before the radioiodine treatment. So there is a need to emphasize on the long-term follow-up as well as early detection of hypothyroidism in those patients who undergone the radioiodine therapy. Now we're going to move to the thyroid cancer. It occurs in the cells of the thyroid, the butterfly-shaped gland which located at the base of the neck that produces the hormone. The thyroid cancer type and incidence for the papillary and or mixed papillary follicular thyroid cancer is about 85%. Follicular and Hurthal cell thyroid cancer is about 10%. Medullary thyroid cancer about 3%, as well as anaplastic thyroid cancer. So the main treatments of the surgery, radioiodine treatment, external radiotherapy, as well as chemotherapy and targeted therapy. So the use of iodine 131 is actually in the treatment of benign thyroid disease such as hyperthyroidism, under the for the grave disease, toxic multinodular goiter, as well as hyperfunctioning thyroid nodules, as well as non-toxic multinodular goiter. So the dose will be in a range of about 8 to 25 mci, whereas if the thyroid carcinoma patient, either follicular and papillary, it will range between 30 to 150 mci. And on top of this, iodine 131 can also be used for the whole body scan in diagnostic with the sodium iodide. In some center, they are using 3 mci, whereas in some centers, they're using 5 mci's. So this is an example of our sodium iodide in either oral. So what is iodine 131? Is an radioisotope of iodine, either iodine 123, 124, 125, as well 127. So it has 53 proton and 78 neutron. The radioactive decay half-life is about 8 days or 192.48 hours. So you can see that the half-life is so long. So this is why it required for the patient to be quarantined for about 1 week if they actually ingest this radioiodine, to make sure that the background level goes to the normal reading. So iodine 131 is produced from a nuclear reactor by neutron irradiation of a natural tellurium target. It decay by because it's produced from the nuclear reactor, and currently our nuclear reactor in agency nuclear won't be able to produce iodine 131. So in most of the nuclear medicine department, we have to import it from overseas. It decay by beta and gamma emission to stable xenon 133. And the energy of principle, they have beta particles about 606 keV. So this is meant for for the treatment, and it also has gamma ray with the 364 keV that can be used for the imaging or diagnostic. So this is one of the very important parameters that iodine 131 has, because it has both properties, beta as well as gamma. So it can be used for those imaging as well as therapeutic. And because of this gamma ray with a very high energy of 364, if you can remember the technetium 99M, the gamma is only 140 keV. So with the high energy of gamma for the iodine 131, we have to take an extra precaution when we are dealing with it. So this is the reason why our lead shield need to be thicker compared to the one that we are using for the technetium 99M, right? So this is the mechanism of action. It incorporates into the iodine metabolic pathway via the sodium iodide symporter. So the treatment of thyroid cancer with iodine 131, it is taken by mouth as a capsule or solution. The usual dose for treating thyroid cancer is about 30 to 200 millicuries depending on cancer stage. But in Institute Cancer Negara, we can go beyond 200 mci after we do the patient dosimetry, meaning we calculate the amount of activities needed for the patient. Then only we identify how much activity that we require to give it. And then the doses may be repeated in 6 months or 1 year. High dose treatment usually requires 2 to 3 days of hospitalization. Okay, so some center it give the iodine during on the Monday, and then the patient will be discharged on Friday after they've done this scanning. For this therapy to be effective, there must be high level of thyroid stimulating hormone, the TSH or thyrotrophin, in the blood. So this hormone can be injected prior to the treatment lah. You can give the thyrogen to the patient. So, contraindicated in patients with vomiting and diarrhea, pregnancy, or who may become pregnant, as well as breastfeeding lah. Because when giving to a nursing mother radioactive iodine, they can reach a baby through the breast milk. So most physicians feel that this procedure should not be used in women who are breastfeeding unless they are willing to cease breastfeeding their newborn lah. Recommended. Okay, that's. In terms of the patient preparation, there would be a food-drug interaction in the food containing iodine, such as iodized salt, seafood, cabbage, kale, or turnips. So it should be avoided for several weeks, about 2 weeks prior to the treatment with the sodium iodide 131. The iodine in this food will be taken out by the thyroid, so it will reduce the amount of radioiodine that can be taken up. Since the exposure rate on the outside of shipping box may be quite high for the product preparation, there need an adequate precautions taken when transporting as well as receiving the sources. So this iodine 131 also need to be prepared under a fume hood or safety cabinet prior administration to the patient, and then the activity measured in a dose calibrator and verify it need to be within 10% of the prescribed doses. So this is an example of how we prepare the radioiodine inside the fume hood or safety cabinet. We need to ensure that we're working behind the lead shell, and obviously we're wearing the glove, if possible, a double layer. And then in terms of preparation of the iodine 131, we need to draw the radioiodine dose in a right dose, check the prescribed dose given, calculate the preparation dose, and withdraw the dose accordingly lah. Then measure the dose withdrawn using dose calibrator, transfer the dose into the appropriate administration container, and we have to clearly label the container. During dispensing of iodine 131, we have to ensure that we are going to give it to the right patient. So we have to call patient, ensure correct patient is present, and ensure correct dose drawn up to that particular patient. So we have to verify first the patients whether it's the right one, and then we give instruction to the patient how to actually ingest the radioiodine. Because we have to ensure that we give a preliminary instruction. Then when the patient ingests, we hope that there's no questions come from the patient, because when the patient has already ingested the iodine, they become a radioactive materials, meaning they will give the radiation and it will radiate us who are actually near to the patient. So we used to have we used to give all the instruction that needed, and then we will ask the patient if they have any question. So we will try to answer and give the answer before they ingest the iodine. So right after they already ingest the iodine, they can directly go back to their wards. Go back into their rooms, or they can leave the department, because we just don't want them to radiate our personnel who are giving the iodine. So these need a directly observe radioiodine therapy. We have to see whether they really ingest those radioiodine, and obviously the disposal of radioiodine waste is very important. You have to ensure that you don't mix these iodine 131 with the technetium 99M waste, because it has a longer half-life, so it needs a longer time for it activity to goes into the background normal background level. Okay. These are steps to be followed after treatment with iodine-131. It is very important to drink plenty of liquids, water, and to urinate often. After treatment with the sodium iodide, this flushes the radioiodine from the body. And then to reduce the risk of contaminating the environment or other people, the following procedure should be followed at least 1 week after treatment with the iodine 131. They need to avoid close contact with others, especially the pregnant woman, kids and baby. They have to keep distance, not less than 1 meter, sleep separately, and also avoid from public lah. They are also recommended to flush the toilet twice after each use, washing hand after using or cleaning the toilet. They have to avoid handling another person's eating utensils. So we used to actually advise them not to prepare food for other people, not doing the cooking lah. Using separate wash clothes and towels, because it will come through the sweat. So we just don't want, because when patients sweating, the iodine might actually be at their washcloth or towels. So this is why we ask them to wash the clothes, bed linen, and dishes separately. And then in terms of ADR, the common adverse reaction to the sodium iodide therapy will include GI, nausea and vomiting. In terms of cardiovascular, chest pain and tachycardia. Allergy, it will involve itching skin, rash and hive. Tenderness and swelling of the neck, pain on swallowing, sore throat and cough have been reported, generally around the third day after sodium iodide administration. And the long-term side effect is the hypothyroidism, so need to take the thyroid pill for the rest of the life. Okay, and now we are going to move to the neuroendocrine tumor, yeah? So NET is a neoplasm that arises from cell of the endocrine, the hormonal as well as nervous system. It shares common features, the similar microscopic features, having special secretory granules and often producing biogenic amines and polypeptide hormones lah. It arises from various neuroendocrine cells whose normal function is to serve at the neuroendocrine interface. The cells present not only in endocrine gland throughout the body that produce hormone, but also diffusely in all body tissue. So NET shows a amine precursor, the L-DOPA and 5-hydroxytryptophan uptake and decarboxylation to produce biogene amines such as catecholamines as well as serotonin. So the characteristic of an ET, it is rare, usually small, less than 1 centimeter, slow growing, month to years, cancer in slow motion. It is usually metastasized before becoming symptomatic, often when tumor is less than 2 centimeter. The expression is episodic, may be silent for years. Symptoms mimic commonplace condition and often are mixed diagnosed lah. Types of NET, various types of NET can occur in many places in the body and grows differently. Many NET first appear in the lung of the GI tract, including the stomach, pancreas, appendix, intestine, colon, and rectum. It may also appear in the thymus, thyroid gland, adrenal gland, and pituitary gland. So it may be classified by the site of origin. The doctors may use terms such as GI NET, pancreatic NET, or lung NET to describe this tumor lah. Although NET vary in size and how quickly they grow, almost all NET are considered to be malignant or cancerous. So this is the classification of the NET by sites of the tumor. Okay, and obviously it needs a multidisciplinary management team. It's either surgery, which needs surgical removal of the primary tumor, or it it might need the medical oncology because it depends on the type of NET and treatment goals. So the chemo, hormone therapy or targeted therapy may be used to manage a certain type of that NET. In terms of radiation oncology, it is generally used when an ET has spread or is in a location that makes surgery is difficult. Okay. And in terms of interventional radiology, radiofrequency ablation may be used for NET which that have spread to the liver, and this might use a high energy radio wave to hit and destroy the cancerous cells. Okay. And sometimes the gastrointestinal procedures, it provide a full range of treatment option for the GI of the neck. And obviously pain management is also important for the patient, as well as nutrition therapy is needed. Okay. So, what we have for the neuroendocrine tumor imaging, we have MIBG at our nuclear medicine department. It is also known as iobiguane. It's an analog of norepinephrine that is concentrated in the sympathetic nervous tissue and taken up into the tumor tissue. A combination of benzyl group of beryllium and the guanidine group, it resembles the norepinephrine and guanidine and other neuroendocrine cells by the active uptake mechanism. It shares the same pathway as norepinephrine. This MIBG we can use with the iodine 123 or iodine 131 lah. And the iodine 131 MIBG is taken up in 90% of neuroendocrine tumors, and it is sensitive and specific for the imaging and also therapy. This is the indication for the use of radiolabeled MIBG in inoperable pheochromocytoma, paraganglioma, carcinoid tumor, neuroblastoma, as well as medullary thyroid carcinoma. So this is an example of iodine 131 MIBG scan in those indication. And this is the mechanism of action, how it be taken up by the cells, yeah? So it's either the neuronal uptake 1 mechanism or by passive diffusion and stored in the neurosecretory granules. The transfer of MIBG from intracellular cytoplasm into the catecholamine storage vesicle, they are mediated by an ATPase-dependent proton pump. Unlike the noradrenaline, MIBG is not metabolized and it is excreted unchanged. The presumed mechanism of action is the emission of ionizing radiation from the decaying radionuclide iodine 131 or iodine 123. So this MIBG is not only used for diagnostic, but it also be used for the therapeutic. In terms of the patient preparation, there is a need to prepare the patient by administering the thyroid blockage agent. So this is the list of the thyroid blockade agent that can be used. Yeah, the treatment should be begin 48 to 24 hours before the planned MIBG administration, and also continue for about 10 to 15 days post therapy. So there is the list of those pharmaceutical that can be used to block the thyroid of the patients before we give the MIBG. So the purpose of thyroid blockade is to reduce the radiation dose to the thyroid, which caused by the absorption of the free or unbound component of the radiopharmaceutical. For the MIBG diagnostic, we're giving the Lugol's iodine 1%, 1 ml BD for a total of 5 days given orally, starting 1 day before injection of iodine 131 MIBG. For the therapy, starting about 1 to 2 days before and continued for about 10 to 15 days post therapy. Okay. So high specific activity is recommended for therapy use. The radionuclide is applied frozen, in aqueous solution or in glucose solution if it's the high dose IBG. It is essential that the manufacturer's instructions are adhered to prevent deterioration of the product. The impurities, the free iodide will not contribute to tumor targeting but may contribute to the side effect of the treatment. So when necessary, defrost is achieved by placing the vial within its lead container in less than 50 degrees water bath for about 45 minutes. And then the sample is withdrawn for quality control of radionuclide and radiochemical purity, or some of the center they just use the certificate of analysis to confirm the results of the RCP and others. So this is an example of the iodine 131 for the diagnostic purposes. From GE Healthcare, it's about 2 millicurie per vial, so 2 patients per vial, because approximately about 1 MCI per patient. And then this is the therapy doses from the Unstore Health. It's about 200 millicurie per patient. Now we're going to move into the peptide receptor radionuclide therapy, or we call it as a PRRT. So PRRT with radiolabeled somatostatin analog peptide was developed in the early 1990s as the next logical step of the somatostatin receptor mediated radionuclide localization of the NET. So the somatostatin analog, generally an octreotide derivative is an agonist which is linked to a DOTA chelator that contain a radionuclide. So after binding to the membrane somatostatin receptor, the SSR, the radiopeptide they will internalize, and it is transported into the intracellular receptor recycling compartment. Recently introduced SSR antagonists have overturned this principle, having proven to have significantly lower internalization but a greater binding, owing to the recruitment of inactive SSRs on the surface of the neuroendocrine tumor cells. So this is the mechanism of action for the PRRT. Okay, after initial experience with the diagnostic radionuclide indium 111, octreotide, in an attempt to exploit the Auger and conversion electron emission of indium 111, the past 2 decades have seen the use of the most suitable beta emitters, such as yttrium-90 and then later using the lutetium 177. So because those give a longer range of emission. So these therapeutic strategies has been accepted as an effective therapeutic modality in the treatment of inoperable or metastatic gastroenteropancreatic and bronchopulmonary NETs, as well as for chemocytomas and also paragangliomas. So the two most commonly used radiopeptides for the PRI. So there is one studies, NETA-1 trial. It is in the first 3 registration trial. It demonstrated a significantly longer progression free survival in patient with a small bowel NET treated with 177 lutate 177 octreotide plus 30 milligram long-acting release octreotide. Then in those who are only treated with the 60 milligram long-acting release octreotide. So in addition to the tumor responses, symptomatic and quality of life improvement is commonly observed and was confirmed. So these results compare favorably with the efficacy of cold somatostatin analog, chemotherapy and targeted therapy, such as everolimus and sunitinib therapies. So a major advantage of PRRT over conventional treatment is the possibility to identify and also quantify the target, the somatostatin receptor, before we initiate the therapy in the most classic of the theranostic approach lah, because we've got this gamma and beta properties. So with the gamma, we can actually identify and quantify dulu the target, and then we can use the beta properties to actually destruct the area. Recently, the PRRT strategy against somatostatin receptor positive cancer was also extended to the delivery of the alpha emitters such as the lead 212. Okay, thank you. We will actually continue in our second part of the lecture afterwards, yeah?